When you think of a skeleton, you probably picture a rigid, lifeless scaffold, but the truth is entirely different. Every decade, your body completely dissolves and replaces nearly every bone you have. This continuous turnover is driven by a biological engine called the bone remodeling unit, or BRU. Right now, millions of these specialized units are actively moving through your skeleton, searching for microscopic structural damage and coordinating its repair. This diagram illustrates the first phase of repair. The process starts with the demolition team, the osteoclast. Derived from hematopoietic stem cells, it attaches to the bone surface, creating a tight seal. Inside that sealed zone, it pumps out hydrogen ions to create a highly acidic environment, dissolving the crystalline bone matrix into a tiny pit called a Hauschep lacuna, while proteases degrade the collagen. Once the pit is cleared, the osteoclast undergoes apoptosis. Immediately, the construction team arrives. These osteoblasts, from mesenchymal stem cells, enter the exact same pit, laying down fresh, flexible layers of type 1 collagen. To harden that collagen, the osteoblasts transport calcium and phosphate into the pit, mineralizing the soft tissue back into a rigid structure. As this new matrix solidifies, some of those osteoblasts become permanently trapped inside it. They mature into osteocytes, acting as mechanical sensors embedded deep within the bone. In a healthy adult, overall bone mass remains perfectly stable because it follows a strict rule. The amount of bone resorbed by the osteoclast exactly matches the amount formed by the osteoblast. The two processes are perfectly coupled. That mineralization process cannot happen passively. To build solid bone, the BRU must physically isolate its workspace from the rest of the body's extracellular fluid. A cohort of osteoblasts links together using tight junctions and gap junctions. This creates a unified, impermeable biological barrier over the active site. If the environment becomes too acidic, the minerals will simply dissolve again, so the osteoblasts must actively pump acid out of that sealed compartment to maintain the precise pH needed for crystallization. At the same time, they use facilitated transport to pull in calcium, while enzymes like alkaline phosphatase actively pump in phosphate to force the mineral precipitation. Bone formation is a highly regulated, active biochemical transform engine driven by an integrated cellular network. This X-ray, taken in 1919, shows what happens when forces exceed the skeleton's capacity. A fracture is the ultimate test of the system's adaptability, forcing it to pivot from daily maintenance to acute repair. How the bone heals depends entirely on a physical variable called mechanical strain. In orthopedics, strain refers specifically to the degree of micromovement present below 2%. The body triggers a highly specific algorithm, primary bone healing. This vector visualization shows how medicine achieves that exact state. By surgically installing a rigid metal plate, movement is eliminated, securing a sub-2% strain environment. Under these conditions, osteoclast cutting cones drill straight across the fracture line, with osteoblasts following to fill the tunnel. Because absolute mechanical stability is guaranteed, the bone bypasses its emergency repair protocols entirely and heals the fracture directly through Haversian remodeling. However, if the mechanical strain at the fracture gap rises between 2 and 10%, a second pathway is triggered, secondary bone healing. Because the gap is too unstable for direct remodeling, the body initiates a triage protocol. It forms a deep red hematoma between the jagged bone ends, serving as a biological scaffold to recruit mesenchymal stem cells. This mapping illustrates the response. Local hypoxia and 2 to 10% strain forces recruited stem cells to undergo chondrogenesis, building a temporary fibrocartilaginous soft callus. Once stabilized, osteoblasts invade through endochondral ossification, replacing that cartilage with a chaotic web of calcified woven bone. Over the following months, the bone remodeling units break down that disorganized woven bone and, following the stress vectors of Wolff's Law, realign it into strong lamellar bone. But there is a strict biological limit. If the mechanical strain at the site exceeds 10%, the cellular bridging and new blood vessels are physically torn apart, resulting in a non-union where the bone fails to heal. The degree of physical strain acts as a mechanical switch, entirely dictating which cellular algorithm the body executes to repair the skeleton. That precision can fail with age. In postmenopausal osteoporosis, the drop in estrogen causes the bone remodeling unit to uncouple. Resorptive activity increases while formation slows down, leading to rapid bone loss. To combat this, medicine relies on powerful anti-resorptive drugs like denosumab, which are designed to completely shut down osteoclast activity. This creates a professional paradox. If osteoclasts are halted, the perfectly coupled remodeling cycle must also stop. So how do these drugs result in net bone mass gains at sites like the hip? To find the solution, we have to look past the coupled cycle of repair and at how osteoblasts can function independently. We are looking for a process where new matrix is laid down without a preceding signals from an osteoclast. Under a microscope, a histological tracing shows a wavy, scalloped cement line, the signature of remodeling, where bone is built on a surface carved by acid. But perfectly flat cement lines indicate osteoblasts building directly onto an unresorbed surface, expanding the bone's outer boundary. This independent process is known as bone modeling. While remodeling is an engine for maintaining existing tissue, modeling is the true mechanism for adding net new structure to the skeleton. This 3D diagram details the mechanism of denosumab. The antibody physically blocks the rank L receptor on an osteoclast precursor, preventing its activation. By shutting down the demolition team, the drug effectively freezes the detrimental remodeling cycle, successfully halting the loss of internal cortical bone. Crucially, this cross-section reveals what happens next. While internal remodeling is frozen, the drug is permissive to modeling. Osteoblasts on the outer periosteal surface continue to function unabated, adding a bright green layer of new bone. This de novo periosteal modeling is actively driven by mechanical load and strain, proving the system is still calculating and responding to physical stress. Identifying these strict boundaries between remodeling, modeling, and strain thresholds allows clinicians to actively engineer human skeletal integrity.